Hi, my fellow providers at IHH. I'm so excited to be part of you in 2025. So I wanted to make a few videos that hopefully will be helpful for those providers that want to work with cancer patients. So I still have so much to learn, but things that I've learned over the last 5 years. So, and any of you are welcome. If you like my note that I use for cancer patients, you're welcome to use that template. Just ask me to share that with you. But when I have a new patient, what I usually do, I have a standard template that's been helpful for me. And then I go to the last provider, HEMONC. I have a tab on my folder that says HEMONC, so I could just find who the oncologist is. I go to their last note or the radiologist's last note. And then every oncologist does it different, but whatever their most recent history was and an update. And that gives me an idea how long they've had cancer. Sometimes they don't have it in their most recent note if they have chronic cancer. So I go scroll it. I screen out only HEMONC notes, and I go to the bottom when they say new patient. And then that gives me an idea when they started this journey of cancer. And then I copy off what surgeries they've had, oncology surgeries, radiation, chemotherapies, so that I have an idea of what they've been through before I see them, and then what they're taking currently, so that I know every time you note, okay, this is what they're on currently. And then I usually also go to their last imaging, their last CAT scan, and then I look at the summary so that if I know if there's a recurrence or what's going on with their recent surgeries. And then of course, looking at the recent lab work, copy off their recent CBC, CMP, and then any other pertinent labs, and then I paste that into my notes. So that when I do see them, that gives me a good picture of where they're at with things. I also use what I got from IHH a while back, the MSQ. I think you have another one that that you use also similar to that. But then Sarah, my MA, sends the MSQ beforehand, or if she has time, if they haven't filled it out, she goes over that with them. And that on that initial visit really gives me a good idea too where are the problem areas, and I don't have to spend time asking them or specific things, or I can refer to them saying, oh, I see you marked a 2 out of 4 on your digestion for constipation, and then that it saves time. So in regards to the once I know the chemotherapy they're on, then that gives me an idea of what supplements I can use. I just sent, in one of the last videos, there's a summary for the nurses on HEMONC that you might also find helpful. You want to review that, and I won't go over all those same things in detail, but those are various supplements that we can use, and it describes those. One of the distinctions that's important is if they're on a type of immunotherapy that's called a PD-L1 inhibitor or an immune checkpoint inhibitor. That's really important. Those common ones are Keytruda, Opdivo, Tecentriq. That's the other one. Those are the main ones that are the PD-L1s. Those are in a different class than the other immune therapies like Herceptin, because with the PD-L1s, we don't want to use the beta-glucans, turkey tail, reishi mushrooms, and the different beta-glucans like that in high doses. So, 500 milligrams eating mushrooms, no problem. But using, we want to, in other types of chemos, we generally want to use the higher doses of beta-glucans, something like 2,000 to 3,000 milligrams a day in divided doses. And with that said, if we're using a food or a supplement for cancer, targeting cancer cells, we want to have a rotation of those. We don't want to use turkey tail for 2 years. We want to rotate it. We don't know exactly how to rotate that, but I just sort of guesstimate, okay, 4 to 6 months on one, then maybe mix it up with only 1 capsule of turkey tail and reishi, and then switch it around, but favoring more turkey tail for breast cancer. I have to get my list out. Reishi, I think, is more colon, and lion's mane for lung. I have to relook at that. I should have had that ready for this video, but that's all right. In general, the beta-glucans in general are important. For the kidneys, cordyceps, which is one of the beta-glucans, works great. A lot of good studies on that, building kidney function. So if their GFR is going below 50, or for whatever reason they're even finished with cancer, but their GFR is real low and I want to boost it up, I'll use, according to Dr. James Lavelle, who taught in my training, 4,000 milligrams of cordyceps. Often they just don't want to take that many pills, so they'll sometimes use 3,000, but I've had some good effect at raising the GFR with that. And it builds natural killer cells, so it's a good win-win. A lot of studies on cordyceps during chemotherapy, so that would be another good mushroom to intermix in, particularly during chemo or people on chronic cancer treatment. With the blood cancer, so it's controversial also using the beta-glucans with blood cancers or lymphomas. So low doses, I would stay more with low doses for those types of cancers also, not using high doses. Although in McKinney's book, so it's a book that I use on integrative oncology by McKinney. Hopefully I'll have that available for everyone who wants to use it on site in Roseville. In that book, they do talk about in lymphomas using the beta-glucans, so it is controversial. We really don't know everything about that from what I've read and practiced. But with the other types of immunotherapy, like the monoclonal antibodies, it is an immunotherapy, but we have a lot of freedom to use some antioxidants with that if that's all that they're on, the monoclonal antibodies. Same with some of the other monoclonal antibodies or targeted chemotherapies that are not PD-L1. We have more freedom to use some lower dose antioxidants and multivitamins. During most of the harsher chemotherapies, for example, someone on breast cancer treatment, someone on colon cancer treatment, like with FOLFOX for the colon cancer or pancreatic cancer treatment, or uterine cancer treatment that are on similar chemotherapies that the breast cancer treatments are on. We're really limited on using antioxidants, and we really want to try to get it through food. Although sometimes I'll use a food-based multivitamin like Kirkland's Organic multivitamin. They feel better that they're doing something, but it's because it's food-based and has really low dose things. The oncologists are usually okay with it. Every oncologist is a little bit different. So Dr. Reddy, for example, is more liberal with using supplements and is very open. In fact, recently just told Dr. Mark Velez that he's good with using some Chinese medicine for some neuropathy during chemo for one of his patients. But then Dr. Chalapa will not, no, vitamin D and some magnesium, okay, but kind of nothing else. She's not open to that. Dr. Babolis doesn't like probiotics. And in regards to probiotics, let me have a word on that one. It's controversial. So Dr. Stacy DeAndre, who started the program, used them in everyone. Dr. Babolis is nervous about using it because in a handful of studies, people on bone marrow transplants, the lactobacillus went into the bloodstream and caused them to be septic. So I tell patients, until you know how your blood count is doing. So this last patient I saw with metastatic breast cancer, on her first chemo, her neutrophils were below 2.5, and white counts were staying low. So I wouldn't use sauerkraut or probiotics with her, just to be conservative. And then this new chemo regime she's on for the last 3 months, she's not had any problem with the white counts or dipping, and so she'd have more freedom doing that. So that would be my advice in reusing the probiotics. So I do use more prebiotic powders. Kombucha should be fine, but again, potentially controversial if they're really neutropenic. And so at the beginning of treatment, say a breast cancer, uterine cancer, some of the other cancer treatment, be cautious on suggesting probiotics and live prebiotics for that reason, till you know kind of where they're at with things. I do, so that's a summary just of the different kinds of chemotherapies in general. I do use, in regards to prebiotics, do use a lot of psyllium husk, organic psyllium husk, because it both helps diarrhea and constipation. They get constipated from the Zofran, which most everyone is on. Also, as a note too, they're often on steroids. If they're doing well, they haven't had reactions in the first couple rounds, you can encourage them to talk to their oncologist, and many of them get off the steroids, which often they feel better, and it's of course better for the immune system and other reasons. So you can encourage them to talk to their oncologist regarding tapering down or getting off on that. One of the other tools I'll use during chemotherapy is the fasting mimicking diet. I have a nice smart phrase for that you're welcome to use, just ask me for that. We have to adapt. Dr. Longo's research was on using a 5-day fasting mimicking diet around the time of an every 3-week regime. Most of our patients are on either every 1 week, 2 week, or 3 week. They don't have a protocol for using it for every 2 weeks or every 1 week. Some of it's also based on their weight. So if they're on every 3 weeks, 3 days before, the day of the day after. And that's, as you know, is around 800 calorie to 900 calorie, 50% fat, 40% protein, 40% carb, 10% protein. The other days, then you want to go at higher dose, 1.2 to 1.5 grams of protein per kg to boost up their system, along with light weight lifting to build up muscle tone during those other days. If they're on an every 2-week regime, it's really guesstimate. It depends again on their willingness, but possibly 1 day before, the day of the day after, but not 5 days. If they're on an every week regime, you're really limited. So probably just the day of, they can either fast or do the fasting mimicking diet that 1 day and possibly the night before. So that's how we use the fasting mimicking diet. Why would we want to use it? It definitely lowers the side effects of chemo. Secondly, it puts the body in a ketosis, stresses the cells, so that potentially the chemo has more of a shot at things, and gets at the cancer cells more readily. As maintenance, Walter Longo suggests for someone, say, in remission, 4 to 5 times a year. Someone who has to lose weight, Prolon has a whole regime for that, and you can sign up. We may have that with IHH, I'm not sure, but I have an account with them that they can sign up. I don't get a profit from that, but so it's they can sign up to that, get a consult with the dietitian, and work on a metabolic program with the fasting mimicking diet, which is a great tool. For our breast cancer patients, we have a program on the second floor called the Oncology Support Clinic. A nurse practitioner, Alyssa Eukener, runs that. She'll start in full-time this month, December 2024. And all of our breast cancer patients should go to them, so we would really be a background support if we're also seeing them. But if they haven't gotten a referral to the supportive oncology clinic, you could make sure they have that and just message the oncologist to make sure they put that support in. So that's what's stage 1 through 4 breast cancer should go to the supportive oncology clinic, and then we would see all other cancers. It's not wrong for us to see them, but that's probably the right order of things. Our pancreatic cancer patients, most all of them need to be on a prescription pancreatic enzyme supplement like Creon or pancreatin, and that would be either their family doctor. We don't need to get involved in ordering that, or the oncologist. And the over-the-counter pancreatic enzymes, now betaine may still be helpful. I'm actually not sure if they actually still need pancreatic enzymes if they're taking Creon. So that's something I have to look into. I don't know the answer to that. But you'd still want to test their HCl with the baking soda challenge test, the 4th teaspoon of baking soda and 4 ounces of water, and see if they burp after 5 minutes. And if they don't, they need some support to help their acid. If they're on a proton pump inhibitor, see if you can work to get them off that. They should be gluten-free. Anyone who's had cancer, I believe they should be gluten-free. Or at least just if they don't have a high CRP, above CRP high sensitivity, which I always test. If they have a low one, under 1, then they might do okay with sourdough, organic sourdough bread. But it should be low carb anyways. We say cancer is a metabolic disease unless proven otherwise. So unless their insulin is a 5 or 4 and their A1C is below 5, then I consider it most likely a metabolic disease. So then they should be low carb, lots of veggies. They do not have to go vegan, so it's confusing when I started because so many professionals said, if you have cancer, you should be a vegan, never have dairy. Alyssa Euchner and I and Christy Howlett all agree, no, the source is what's important. So grass-fed cows will produce good milk for yogurt and limited quality cheese and meat and grass-fed beef and lamb, etc. So again, the source and quality. Same with eggs. Patients will ask you, can I eat eggs? I heard eggs are bad. There was a study out of UCSF a few years ago, but the study wasn't clear as to, quality eggs versus cheaper eggs. So I tell them Dr. Mark Hyman says 8 eggs a week, so just keep it at that. So those are common questions you'll get from cancer patients. If they feel better being vegan, you can do that for a time, but most of them, a lot of people just need that protein and need that. It's very hard to be and keep, low carb if you're not eating quality meat and fish. So that's something to consider. But as a whole, we're not against those sources of protein. Alcohol is a big question that comes up. Different opinions, as usual, but we know alcohol, there's a direct correlation, more alcohol, more chances of cancer. So quality and amount. The least is better. If you're gonna have it, I tell people on the weekends, have a serving or 2, but no chew buck chuck. Have some quality wine. And Christy Howlett would always proposed having more European wines that tend to not use the pesticides and extra ingredients that we use in America. So you can keep that in mind also. And if they're not going to drink, then have some special, the time they have with their friends and loved ones of what they were used to, having a drink before at some point in the day, then put fizzy water with some berries or something in a glass of wine or a wine glass, and still have that try to have that quality time, or a little bit of kombucha, or something that they can learn to enjoy, but have that really good time with their loved ones and friends. Back to the CRP. Many integrative oncology people do not test the CRP when they're on chemotherapy because it often is high, but I have practiced differently and found it helpful. I like to test it to see if we can get it down through any dietary changes while they're on chemo, regardless if they're on chemo. But often when they're on the PD-L1 immunotherapy, the one I had mentioned, so that's the immune checkpoint inhibitors, it will be high. But for example, recently I had a woman, she was normally on the Keytruda, which is that PD-L1 inhibitor. She was like a 3.0 CRP, high sensitivity, and then it jumped up to 19. And I said, because potentially she's getting one of the side effects of the PD-L1s is they get a pneumonitis, they get a colitis, they get a secondary autoimmune disease from that, unfortunately. So sometimes that high CRP can be, oops, something's starting, and we can maybe catch that. So I'll alert the, if we can't find a source for it when I'm seeing them, then I'll alert the oncologist that, hey, let's follow up on that, or I'll check him in another 10 days. And if it's even higher, then I would alert the oncologist that something's going on inflammatory wise that doesn't seem normal. Can you let's keep an eye on it, or get a chest x-ray, or look for any colitis or pneumonitis. So that's a big thing that I watch for. But I do a lot of food elimination diet with gluten-free diet, and I just say there's so much stress. So even just within 2 weeks, sometimes I see a change in that CRP. So how I explain to them how to do the food elimination diet, I give the example of, if this computer here is all jacked up and I can't type anything, it's frozen, what do? I turn it off and I wait. And then after about 30 seconds, I turn it back on, and it usually works. So I tell them that's what we're doing with your immune system. If gluten or another food is causing your immune system to be all jacked up, then we have to completely turn it off for at least 3 weeks, preferably 8 weeks, but most people can't go that long. So I say, let's do it for 3 weeks, and then let's retest the CRP. It's non-fasting, just go in anytime, get that when you've done that. Gluten elimination diet, let's check it again. Then I tell them, even if you don't eat it, but you lick the bread, it still counts, because it's going to trigger the immune system. So even a crumb or a bite. So I have to explain that to them in that detail, because oftentimes if they see that, oh my gosh, my CRP went from 2.0 down to 0.4, oh my gosh, that's incredible. And then I explain to them how beneficial that is, because cancer is an inflammatory disease. And if we can knock down that inflammation, we're knocking one more pathway. Sometimes I'll test their IL-6, because low-dose naltrexone is really helpful with most cancers. A lot of good literature on that. A little caveat with low-dose naltrexone. It's controversial with lymphomas, whether to use it with lymphomas and blood cancers. We still don't know. In some places they say use it, some places they say don't. So I just am more conservative, and I usually don't. In solid cancers and with chemotherapy has really good effect, but with the immune therapy, the immune checkpoint inhibitors, the PD-L1 inhibitors, I don't use it, because we don't know enough of that interaction. When we're using it for other types of cancers, the website LDN Trust states, I think that's the website, LDN Trust. I have it on if you want the info, I can give it to you. They suggest for autoimmune disease, use it every day. For cancer, 3 days on, 3 days off. 3 days on, 3 days off. And that, I believe, is to prevent resistance. So that's how we use it. So if they have both autoimmune and cancer, I would veer on the side of the cancer and do 3 days on, 3 days off. So thanks so much for that little segment on things you can use during chemotherapy, and a few tips of using fasting mimicking diet and low-dose naltrexone. And again, there's another video with a summary for nurses on some other points that go over some of this, but in more broader strokes. Thanks so much. Have a great day.